Welcome, everyone. I'm John Martin, Chief Medical Officer of Butterfly Network, and I'm honored to bring you another edition of our educational webinars. In honor of Mother's Day, we're bringing together tonight an amazing group of humanitarians who've dedicated themselves to address one of the world's greatest ongoing tragedies, maternal fetal mortality. The statistics which we will review with you tonight are painful to accept, and candidly, if they occurred in the developed world, would never be tolerated. Our goal tonight is to shed bright light on this important subject as we celebrate the mothers in our lives and introduce you to some inspiring people doing truly God's work. We're going to discuss the complexities of the problem and the solutions, and finally, hopefully inspire many of you to join their efforts to give expecting mothers a better future. This is a subject that's passionate for us at Butterfly and a core purpose of our existence. And as such, we are honored to have tonight the following guests join us. I will let them introduce themselves and briefly their organizations. And so you'll have context into their insightful comments and appreciate what they have to share with us. Nareen, would you like to go first?
Sure, thanks, John. So initially, thank you, John, and the Butterfly team for this opportunity. My name is Nareen Ahmed. I'm a pulmonary and critical care doctor based in Philadelphia. The first question many people might be wondering is why a pulm critical care doctor is involved in a conversation about maternal health. But mainly my expertise is in the organization and implementation of ultrasound training courses and advocating for local capacity building. So I've created a Train the Trainer course for point of care ultrasound in Bangladesh, which is now self-sustaining for the last 3 years. I'm currently the head of Bridge to Health, head of ultrasound for Bridge to Health, an organization which I'll let Bill speak about a little bit more, and one of the POCUS project coordinators for Med Global, which is a nonprofit that focuses mainly in crisis zones, such as the Rohingya refugee camps in Bangladesh, in Yemen, at the Venezuelan-Colombian border, and Gaza, to name a few. So I'm really happy to be here and can't wait to chat with all of you.
Thank you, Nareen. Anisha, can you go next?
Yeah, absolutely. Hi, everyone. Great to be here with you all today. I'm Anisha. I'm a program officer at the Gates Foundation, and I came to the foundation with a background in medical technology and global health governance and policy, and got the opportunity to work on our maternal newborn child health discovery and tools team, where for the last couple of years I've been developing and managing our portfolio of investments to get low cost, appropriately designed, integrated diagnostics devices, digital tools, AI, to improve essentially the quality of routine prenatal care at the lowest levels of health systems in low and middle income country contexts. And through that portfolio, have been able to be closely involved with the Foundation's partnership with the Butterfly team, since AI-enabled ultrasound is a key component of what we believe will be an important part of a high-quality approach to pregnancy care. So happy to be here today and looking forward to the discussion.
Thanks, Anisha, and we certainly appreciate all the great work the Gates Foundation does on this very subject. Noelle, how are you next?
So my name is Noelle Strong. I am a maternal fetal medicine specialist, which is an OBGYN that specializes in high-risk pregnancies. I am based in New York out of Mount Sinai Hospital, and a side passion of mine that pairs very well with my 9 to 5 is maternal global health. And to that end, I work with an organization called Saving Mothers. We're an organization full of doctors, researchers, and allied health professionals that try to kind of bring low-tech, high-impact solutions to limited resource settings to try to improve maternal and child outcomes. And I've been working with them for over 10 years now, and as a high-risk obstetrician, ultrasound is one of my most valued tools to bring and train local communities in to help improve outcomes. So I'm excited for this discussion tonight.
Well, we're glad to have you. Emilian, you're next.
Sure. I'm Emilian. I'm the founder and CEO of Ilara Health, a venture capital funded venture based in Kenya, more specifically in Nairobi. At Ilara Health, we enable small size clinics located in low and mid-income outskirts of the main African cities to access life-saving point-of-care diagnostics tools. And we partner with companies that are disrupting those, the diagnostic device landscape, such as Butterfly Network, and we integrate their devices into our technology platform and offer this diagnostics package together with smart financing to healthcare facilities in peri-urban areas. And in addition to technology, we provide training to healthcare workers to be able to use those devices and eventually build healthier communities by improving access to diagnostics.
That's great. I mean, this is a really important subject. And as you keep telling us, you got to consider the finance part of this whole equation. Bill, you're next.
Great, thanks for having me. And so I'm an emergency doctor trained in family medicine and public health. And I work in Toronto, teaching at the University of Toronto and Northwestern as well. And I co-founded and am the chair of the board of Bridge to Health Medical and Dental in Canada, co-founded and am CEO of Bridge to Health Medical and Dental USA. And our mission is to basically create a coalition of the willing of sorts between government, civil society, and academia to form comprehensive partnerships to expand healthcare access to rural and underserviced areas around the world. And as part of that mission, we focus on sustainable infrastructure development projects. And we got involved in maternal health years ago, looking at using point-of-care ultrasound in a creative fashion. And then we've since expanded into a variety of different areas. And I'm very grateful that someone who I look up to and respect quite a lot, Professor Okeo, is on the line with us today, as well as a bunch of my other colleagues I had the pleasure of working with. So thanks.
Thanks. And I'm firmly convinced there's actually multiple clones of Bill with as many things that he's involved in. And I'm just not sure which of the ones I'm talking to this evening. All right, we'll move on to Dr. Okeo, our friend who actually is the farthest away from all of us. So live from the middle of the night in Kenya. Dr. Okeo.
Thank you, John. I'm glad to be with the team this evening, a very important topic dear to my heart. I am an obstetrician, gynecologist, and public health specialist. I'm currently head of Obs-Gyne at clinical medicine, Uzima University. Uzima University is a faith-based tertiary institution. I joined earlier this year. And I just want to really appreciate Bill, because Bill introduced me to point-of-care ultrasound a couple of years back. And last year, he introduced me to Papa and Noreen, and I probably didn't have enough time to appreciate that. And at that point, I was not too sure about point-of-care ultrasound, especially in OBS and gyne, but over the time, I have kind of become really a disciple, and I wish I had more platforms to advocate for it. And hopefully when I get a chance later on in the program, I can say a few things in terms of what we need to do about point of care in Kenya, for example. I can only speak where I live. What we need to do as health professionals in moving it from square 2 to 3 and 3 to 4. Thank you very much.
Well, we're thrilled to have you. You're such a critical part of this panel. And as you can see, you actually represent the in-country contingent that are so important. And we realize it's the middle of the night, which is part of the reason why we haven't dragged a number of your colleagues actually onto this with us. But we've also included people here in the United States and Canada for an important reason. And that is because we also want people to understand that they can get involved over here and have an impact over there. And so, you know, we've got you and Emilium as people that are over there on the ground a ton. And then we've got our folks here in the United States and Canada. And we hope to show everyone the kaleidoscope of different ideas and aspects in which this group actually comes together and actually goes to solve these particular problems. So the agenda we'd like to cover tonight is really looking at what this maternal mortality conundrum is. Why is it such a big deal? How sustainability is a really key element that each of our key people here address. What role does imaging play in these low resource settings, and have there been any recent changes that have impacted that? And I think an interesting discussion I hope to have at the end is one of the things that I have certainly learned in my role at Butterfly is how many different organizations are involved in this work in the developing world, and how do we find ways for everyone to coordinate and share their learnings? I think you found already that this group has found a way to talk to one another, but how do we expand on that? So let's talk about what really is this conundrum. Why is this so important? It's Mother's Day. You know, I think there's nothing more important and impactful than talking about mothers. It is obviously in the United States, it's mom and apple pie. It's not dad and apple pie. And so the mother itself becomes a focal point of the family. They drive healthcare decisions. They are really the core of the family, and it's been that way for centuries. Unfortunately, and this is a story I often share, in the developed world, when mothers are pregnant and they get close to the end, they're thinking about, what am I going to name the baby? Is it a boy or a girl? In the developing world, they have this concern of, am I going to be alive to see my baby grow up? And that is incredibly impactful as we think about this special day. So I'll kind of start with Noreen, and you can walk through some of these slides, Noreen, as they pop up. How bad are the statistics, and how variable is the mortality around the globe? I know, some of the statistics will be on the slide, but I think you have a pretty good head on how bad those statistics are. And maybe you and Nisha can go back and forth, because I know both of you know these statistics so well.
Yeah, so, I think in general, the main thing to think about is, first of all, the percentage that exists it's an unacceptably high number. And that number is unacceptably high in the US as well. And I'm sure Noel can kind of speak to that. But the maternal fetal mortality rate abroad is far, far too high. And I think we need to understand the breakdown of that. And I think the conundrum has a lot to do with, one, dissemination of information is also a really, really important thing. And that's starting with the moms themselves. I think we can all agree that if you inform and educate a woman, you really educate and inform a village, right? And so there have been several papers that were published on the absolute power of education in rural village areas. I can speak to this, especially in Bangladesh, where mothers were just taught hygienic birthing practices, and that was an incredibly empowering thing. So now we're leading into this era of still seeing this incredibly high mortality rate and needing to understand why that's the case, and maybe just talking about these hygienic birthing practices and prenatal, and the importance of prenatal care is not enough. And I think talking about how we can then identify patients that are high risk and refer them to where they're needed to go in order to have a safe labor and delivery, I think that's the next step in how we can reduce that number. And I think that's where the conundrum is. I don't think we've fully figured out all the components as to why that mortality rate is so incredibly high.
There you go. 830 women die every day from pregnant-related complications. 830 women a day. That's a striking number.
And it's important to realize that over 3/4 of those are preventable causes. So I think that hammers that home even further.
And I think the next slide identifies where the majority of those are occurring. So I listen, any death in this situation is dreadful. And as I shared with the panelists before we started, my first job in medicine was a corpsman, a technician in labor and delivery. And I know how, I witnessed at a very early age in medicine how devastating all that was from just a worker. I couldn't even imagine it from a family. But, the statistics are out there. 94 to 99% occur in lower and middle income countries, which is why this is so important. Anisha, you guys eat, sleep, and drink statistics there at the Gates Foundation. What else comments do you want to add for our group on why these numbers are the way they are, and how striking they are, and the differences in different countries?
Yeah, it's actually fascinating because we fundamentally, as a global community, lack so much data in this space that we don't even actually agree on. Multiple institutions don't actually even agree on the total number of maternal deaths that there are globally. And it's not minor differences. It could even be double different estimates from each other of major global institutions that set these guidelines. And that just speaks to just a real lack of data and then the prioritization of data in this space. And I think that it's actually, I mean, mortality is higher than we want it to be, but that lack of data translates sort of even more extensively into the morbidity space. It's not just that women are dying, it's that there are long-term sequelae of the morbidity as a result of pregnancies, even when the woman doesn't die, that have significant impacts to their vulnerability in future pregnancies, right? And all the actual obstetricians on this call can comment much more significantly to that. But we lack even more data about that, right? Half of the causes that Noel was speaking to, when we look at the kind of models of data and of the burden of disease, of maternal mortality or morbidity, many of those causes are grouped into indirect causes or unknown causes or other causes in a way that we're really unable to target solutions effectively. And so that's a huge part of what we do at the foundation is funding the generation of more granular, higher quality data that actually represents the context that we're talking about, right? That so that we can translate the evidence of global guidelines and studies to the regions themselves. Otherwise, we won't have solutions that are targeted towards those populations.
Dr. Keo, why are women dying in this situation? How is it, what are the fundamental causes as to why this is occurring?
Well, you know what, just speaking about statistics before I go to the whys, what jumps at me is the serious disparity within and even between countries. For example, in Africa, Syria has a maternal mortality rate of just above 30, while in Southern Sudan, it is 1,150 or thereabout. That is a serious disparity. And what is painful is that most of the causes of maternal mortality have been classified. The biggest cause, of course, is hemorrhage. And we all know how to prevent a death when there is hemorrhage is, number one, to precisely make the diagnosis of what is causing it. And secondly, to act, fast. In a case of a ruptured ectopic, for example, the quick action will save the mother. Otherwise, the mother will bleed to death. And technologies like point of care for a mother presenting with such emergencies in remote rural settings is the first foundation of making that diagnosis before you act. So the causes are known, and the signal functions for emergency care are also known, the 8 or so, 9 of them. And so no wonder we say that most of the maternal deaths can be prevented. If I were to become political, there used to be a narrative of how many plane loads of women die. And I'm looking at where we are now, the COVID pandemic, and the number of deaths and the amount of resources that we put in. If only we put a fraction of that resource, we would wipe out a huge proportion of those plane loads of women dying from childbirth. But in one sentence, most women die in remote rural settings because of infrastructure. But some, if I were to do politically, and by the way, I want to share what one of my colleagues told us, is next time we do this topic, we should change the topic. We shouldn't talk about low resource settings. We should find another term, because even with the limited resources, we could do so much more. So there's the issue of political will and how we allocate resources. And how do we allocate resources, investment, including investment in point of care, is by having the evidence for it. And you've talked about some of the limitations of data. So that's another factor in if we have to address maternal mortality, especially in developing countries.
I think we've been fortunate now. Cliff has joined us. Cliff, are you here? Would you like to introduce yourself? I think you've joined the party.
Yeah, so sorry, I had a little trouble connecting. Just quick introduction. I run a nonprofit organization called the Nyagi Project. We are an education nonprofit. We try to teach ultrasound skills for life-threatening conditions, especially maternal health in, I don't want to say low resource areas because we just mentioned that, but in rural areas where they really could use ultrasound the most, identifying a disease early or potential complicated delivery is what we're focused on. We facilitate with other partners getting ultrasound machines and skills to the rural and remote areas to help pre-identify high-risk problems. So that's a little bit of my background. I've been doing ultrasound for about 20 years. I'm an ultrasound enthusiast by far, and I'm actually a sports medicine physician, but I'm trying to save mothers' lives in remote areas of the world.
So Bill and Amelia, and you guys have really worked on building new programs to overcome. Can you guys talk a little bit about, and then bounce this off each other? I want to shut up and just listen about what you believe were the hurdles to get these programs started, and what you see are the critical aspects of creating sustainability across there. Because we all talk about going in there and doing a good deed, but it doesn't really help unless you create a sustainable program. So I'd love to see the entire group get into a discussion about what are the key hurdles to changing this, and how do we actually create sustainability. And maybe Bill, you'd like to start.
Sure, happy to start, and then Amelia jump in. God, I think the two things for me that are the most important to start, from my perspective, sort of as a Canadian looking to try to get involved in some way to have an impact, is number one, identifying the strength of a partnership. So that's the critical piece at the beginning. And that's sort of the hardest part that can sometimes take us years to sort out, is the right partner to work with. And then, finding funding is always challenging as an NGO. So that's just sort of the nature of the beast. But I think getting, partnerships are so critical for so many reasons. And when we talk about sustainability, I think back to when we started our initiative in Uganda 8 years ago. It actually happened because Dr. Jeffrey Anguyo, who's a Ugandan physician, started an organization called Kihefo in Kampala, Uganda. And I was working on a project on emergency department echo, and we brought a point-of-care ultrasound with us at the time. And he looked at it and said, I didn't know that these existed, but if you could get one of those devices into the villages, it would be too good to be true for a woman in the rural areas to get a free ultrasound scan. And so it was this really interesting synergy between a Ugandan physician who kind of knew the community very well, myself who was working in emergency medicine with more modern high-tech devices, and then working with some of our colleagues to kind of put this together. And so, yeah, I think everything is really heavily dependent on partnership to create sustainability. And then through, the research we were able to do, we were able to kind of build capacity with Kihefo, and they ended up launching a maternal hospital, and they still have devices that we left with them and trained some of their providers on. And they actually went through different programs as well to have ultrasound technicians trained through the governmental system in Uganda.
So both Stephen and Cliff, you mentioned two things: infrastructure and resources. Now, I want to start with infrastructure, actually. So the way we, I spend most of my time in just in the outskirts of Nairobi, so 10, 15 kilometers outside the city, and in Kisumu. There are 15,000 small medical facilities in Kenya. So an average size, or like a big size European country, has 1,000. Kenya has 15,000, but all of them are super, super small. About 65% of those 15,000 are in the outskirts of Kisumu. Well, out of the 15,000, half of them are private, and about 60% of the private facilities are out of Kisumu and out of Nairobi, so in the outskirts of the city. Now, all of them are super small. They do not have money to buy the $40,000 ultrasound, standard ultrasound. They don't have the money to buy the $5,000 ultrasound. They can't buy even the $2,000 ultrasound upfront, the butterfly. So they need financing to be able to buy assets, to be able to use them. I think that's access to there's no infrastructure, so access to a distributed infrastructure is super important. I think the second thing, resources. Now, most of the people living in those outskirts make anywhere between $1.50 and $5 a day, and I'm not talking about slums. I'm talking about like low income settings, highly densely populated settings. Now, when one of those small clinics charges $15 to $20 a scan, a pregnancy scan, like how many people can really pay for those scans? If the scan was $10, it would have been much easier. But it's very, very important to find an economic model to solve the border infrastructure and the resources, because what we believe, it's great to do free, right? but the free needs to end up into a sustainable thing, because otherwise it's not working. It's not ending up in a mass solution, which can really save and make a massive difference.
Yeah.
Let me ask you this question. So, and it's posed to all of you. You know, we talk about postoperative hemorrhage, postpartum hemorrhage, and those complications. How much of the stuff done ahead of time is actually going to change those numbers? What are the key things that could be done in anticipation of delivery that could dramatically change the outcome? So, how much of it is truly preventable? Noelle, you said all of these are preventable. They are. How? How are they?
So I think a big piece of that lies in identifying women that have outstanding risk factors for this complication. So anybody can have a postpartum hemorrhage, anybody can have a postoperative hemorrhage, but there are certainly women that are going to be at much greater risk for this. Women with multiple gestations, twins, women that have abnormal placentation, like a low-lying placenta or previa, women who have very large babies, women who have excessive fluid. So things that you can diagnose with a simple ultrasound and then risk somebody out from necessarily being a good candidate for maybe a traditional at-home birth, or a birth maybe can be in the home but needs to be much closer to a health facility, because with all of these obstetrical emergencies, as I can't remember who said it, timing is really crucial, right? Being able to intervene in a very timely manner, anticipating these things and delivering with some sort of skilled birth attendant that can identify a complication quickly and act upon it quickly. So if we have this knowledge a priori, it makes the difference between life and death for many, many women. So it's not to be underscored. You know, you want to say everybody is at risk, but there are certainly women that are going to flag out and maybe need to be much closer to resources in a hospital setting or in town rather than in the remote outskirts where it's going to take them excessive amounts of time to access any sort of health provider.
I think that's a great segue into how you operationalize that, right? And I think one of the biggest things that we find in many of us that work in these rural areas is the lack of providers. So how do you start task shifting people to identify those patients in places where you're not going to have an abundance of healthcare providers that are maybe already experts in the field? And I think that goes to the answer to your question, John, about how do you make this sustainable? How do you create a program that's effective? And I think a lot of that lies in understanding what the local need is from the number of healthcare providers that are available, what they can do, finding local champions like Dr. Okeo who can push forward the training and education of those that we're shifting into that role. For instance, there are plenty of studies that are done showing that you can train midwives or mid-level or other mid-level providers in point of care ultrasound in OB. It's possible. It's just needing a system that works from the front end to the back end. So that means starting with the local champions, continuing education. How do you continue that in areas that are hard to reach? And then furthering on the back end of it, when you start to identify more patients, are the local or regional centers that are going to be accepting those patients, are they ready to do that? Do they have the capacity, and are they able to maintain and take care of these patients once the increase in influx happens at that point too? So I think really talking about that, about how do you truly operationalize that sustainability from the front end to the back end of this, I think is so incredibly important.
So you brought a good point here, interesting point, which is training, right? So one is lack of providers, but the second is even the providers which exist, that all those small facilities are run by nurses or by clinical officers. We've seen very, very few doctors in the more than 1,000 facilities that I've seen myself 500 of them. So training is super important. Now the question here is it possible? How much training face-to-face can be done? And that's where I think that technology is super important, because kind of in the butterfly model with a telemedicine telehealth solution can solve a massive issue. One of the biggest issues that we see actually in those facilities is that even if they need to call a locum sonographer who needs to come and do the scan, but there are very few sonographers. They're far away. It takes them an hour, 2 hours to come by motorbike. Even in rural areas, it's even more difficult. They're even absent, actually. So it's very difficult to find someone to train. So that's where actually the technology and then augmented different using technology to replace or to help humans, and sometimes to replace humans, is actually the solution, and using someone remotely to do those scans may be the solution.
Yeah, I fully agree. I think we're learning so much about the use of technology in this pandemic, right? I mean, I think this platform in particular kind of speaks to that. And those of us that are on Zoom calls on and off to kind of discuss other projects, we are really learning how we can advance forward, because these problems will exist whether this pandemic or the next pandemic is there, and we need to be able to figure out creative ways to fix these issues, even if we can't be on the ground. And utilizing technology, I think, is a big part of that. Of course, there are certain limitations. I think the one that I usually come across is Wi-Fi and the ability to have cell service in certain areas. And I think really talking about every single component of how you make something like this work, down to the tech companies and the telecom companies that are in those areas, and how they can really aid in the usability of technology in those areas. Because I think you're right, Emilian, tech is really going to change the field here, but I think it has to be truly usable in those areas. And I think that's a pretty big limitation as well.
I want to underscore that, like, what we're talking about here, which is I think fairly well accepted by the people on this panel, is actually a pretty fundamental conceptual shift for this field as a whole. And there's two components to it. One is this idea that pregnancy risk stratification, identification early on is possible and is what is needed in order to prevent, mitigate, better equip systems to be able to manage the emergencies that happen at the point of labor and delivery. And I think for a long time, there's been a belief that that's either not possible or not feasible. And the advancements on the data side, the advancements on the analytical tools that we have to be able to develop better algorithms for decision making and risk identification, and those novel point of care tools, whether it's ultrasound or miniature labs platforms or non-invasive sensors, or a whole host of other things that have come to the fore in just the last 5-10 years, makes a really big difference there to our ability to realize that potential. But the other aspect of this is what Emilian and others were talking about, which is that you have a limitation in the system inherently in terms of the providers and the infrastructure that's available. You could go about spending billions and billions of dollars training and making every single one of those people with the tools that exist today able to deliver really, really high quality care at the level of specialists. That is incredibly expensive, will take a really, really long time. And so what are the ways in which we can accelerate that timeline through these types of approaches is just a different way of thinking about this that I think we're all bought into here and really believe in, but is important to I think articulate for the field.
John, if you allow me, can I link what Emilia and Nareen said about having champions and training?
Yeah, and I think your perspective here is really important. What do you need? What do you need?
I looked at the information available within Kenya, and we've actually done point of care ultrasound training since 2013. And I was asking myself, why hasn't it gone up if we look at what is happening now? And I'm saying, in terms of getting trainees to take up training and enjoy the training and to get champions, is to ask the question, is this technology disruptive? And I would, there are two people that I have over the last few days been reading about. Is Ressa Lewis from University of Colorado, who absolutely says that point of care ultrasound is disruptive. And of course, the father of disruption, Christensen, whose view is that healthcare is going to be transformed by point of care ultrasound. And he goes on to say that what we need to do to move forward is to appreciate that disruption of point of care ultrasound is in the process. It has to run its course. And you need champions to move point of focus, disruptive process to its end. And so in terms of my recommendations for health providers is, first, And I can share the links and the literature that point of care ultrasound is a disruption. And number two, how health professionals can participate in moving that disruption process forward.
I think
I
you're
think Stephen,
right.
sorry, go ahead.
I will say, just speaking from experience in working in a division or a subspecialty where it took almost a decade for it to become a part of an integral part of curriculum, because Stephen, you're absolutely right. It is a disruption at first as people start to learn how to utilize the technology until they recognize the benefit of it. But the disruption always happens there because there is a learning curve as well. And until there is some integration, for pulmonary critical care, it had to become a part of the curriculum. It is now starting to become standard of care. That was the lead we followed from emergency medicine. And I think the most important thing is for people to see that there's a true benefit here. And how can we then make this messaging across the board, so it's not just small silos in Kenya or other countries, that we're saying from as high up as possible of the medical education that this is a key part of what should be a part of the curriculum, because that's really what it comes down to. If you really want to upscale this kind of training, I totally agree with you that you have to get the buy-in of the people that find this to be disruptive.
Just 2 points here. So one, like Stephen, you're talking about there's no doubt that the technology is disruptive, and Anisha, you mentioned about the access to it's very expensive to train everyone. The question that I see on a daily basis is how to bring the technology in the hands of the people who can use it, and how to train those people. Now, there's so many clinics because Kenya is so distributed. It's not that you have an ultrasound center and everyone goes there. Each one of those small clinics has their own patients, right? So the women, they go there. So there's no way you can train. Let's say that there 10,000, 12,000 of them, and let's say that maybe 10% or 15% of them will be able to take an ultrasound. It's impossible to train 10, 1,500, 1,000 to 1,500 clinics. So the question is, how do you choose the right clinics, the right facilities, and how do you train them, either face-to-face or through telemedicine or through other solutions? So I think this is super important, because otherwise I see no way to really make this massive impact and solve the problem altogether.
From our experience in Nepal and Haiti, there's a couple of key factors which kind of tie this all together. You're trying to incorporate technology into low resource rural areas, which is challenging in itself, but you can harness the technology to its maximum. We use a software which sits native, embedded on tablet computers that don't require Wi-Fi access. So the curriculum sits in that software that allows the students or whoever's learning to continue learning. Learning ultrasound, like you said, is a very steep learning curve, and I don't know anybody that's really a master ever. You're always learning new things. But if you can get them to feel comfortable using the ultrasound machine in a very basic level, kind of like getting your balance on a bicycle, then it's just a matter of practice. And that's what we found is the hardest part, is to get them to a confidence level where the people can then use it. Because if they don't use the ultrasound machine, which is the fate of many a conscientious ultrasound donation, is the machine is not used because people just don't know how to use it, or they don't feel comfortable doing it. But if the curriculum is such that the basics are low enough and they can feel comfortable doing it, then their reinforcement for using it more and more will grow, and they actually can then teach others. What we've done is it distilled it down to training trainers. We find in-country champions that can actually be the teachers, because we'll bring expert sonographers over to these countries, travel halfway around the world, 36 hours, but we can only spend a few weeks over there and teach them what we know, and then we leave. Key is in my mind, is to find those key partners in country that can then serve as almost like ultrasound school teachers themselves, because they have more access to the midwives and the healthcare providers that go into the rural areas
I've got two things I just wanted to add. One was a comment or a question, I guess, that was in the side box here that I found interesting about, building up tertiary care facilities versus going more into the rural areas. And so I wrote back an answer, but one of the things I wanted to bring up is, it's often really hard to conceptualize the challenges that rural communities have to access healthcare services. And in North America, we have these great roads and infrastructure, and we can access these big hospitals with comprehensive care. But if you're in a rural community, you could be 1 to 2 Canadians use kilometers, 1 to 2 kilometers away from a hospital, and you may as well be on the moon if it's on the other side of a mountain and there's no road and you have no money for fuel or a boda for a motorcycle or some way to get there. And so bringing this technology into those rural areas in an effective and safe and efficient way is ultra important. And then the other component, because of, my sort of NGO hat I'll put on for a second, the idea is, in my perspective, the technology is great and is going to be, and we discussed this in the kind of dry run a little bit, technology is kind of a catalyst in a sense for improving healthcare access, but it's not the entire solution. And we talked about education and partnerships, but once you do an even with the ultrasound scan, ultrasound is a component of antenatal care, but it's not the whole antenatal care, as this panel knows. There's things like folic acid, iron supplementation, syphilis, HIV, malaria screening, family planning for after the pregnancy. And so as folks are listening to this, thinking about designing programs, I would encourage everyone to kind of think about how they can build platforms of care using ultrasound, either as creative incentives or as a component of an antenatal care program. And then don't forget to think about what to do if you diagnose a problem. So if you diagnose twins or anterior placenta or some sort of obstetric complication, make sure that you already have some sort of connection with the tertiary care facility and you've budgeted funds so that your patients are able to get to that tertiary care facility. And these are things that seem like they're, evident or, easy to sort of think through, but they actually, lots of folks don't do it, and then it creates big challenges. And, even when I was at the NIH for a time, part of the problem there was people are very siloed and vertical in kind of their niche and discipline and don't want to, because they're such experts, they think about that particular niche and don't kind of think sort of outside and collaborate with other colleagues. And so that's just what I wanted to advocate for a second.
Can I just make a comment about that and about training? My dream is that one day the butterfly or the advancement of the technology in that direction of miniaturizing it will become the new stethoscope. And I think it is possible. In terms of training, models for training, especially in our settings, a cascade training that Cliff has mentioned part of it. A cascade training is a way of going around the problem of training large numbers. Number two, maintaining competence is in support supervision. Support supervision sometimes is good on paper, but not very good in practice, is to incorporate clinical supervision and skills training during those supervision visits. It requires more time and money, and sometimes if leaders in the managers are not very keen in maternal mortality and maternal health in their hearts, they may not commit that amount of time and money. But I think it is something that is worth looking at. And finally, I just wanted to say that, and this I feel sorry to say, is that the World Health Organization is actually a problem in terms of scaling up point of care ultrasound. And this is why. Because the WHO guidelines put a condition for the use of point of care when you are assessing women. And that putting that condition, I think, should be removed.
We so often, in the United States is a great example, the enemy of good is better. how long does it train somebody? Well, it takes somebody 2 seconds to do an ultrasound to know whether there's one or two. So we don't need perfection here and training experts. They don't have to be experts. And so from the group, all of you think about this. How good do you need to be to make an impact? Because small incremental changes can have a huge impact. So how do you guys decide how good do they need to be to employ this? Because it's hard for me to imagine, and I don't do what you guys do, but even having a little bit of expertise is better than nothing. So where do we draw that line, and how do we do that? And you guys have done the training out there. Nareen, you do these training. How good does somebody need to be?
Okay, let me go first before Nareen. Actually, the literature I've gone through actually states, some of it states very clearly that by the master of disruption himself, that point of care ultrasound has two vulnerabilities. One is what he calls the upmarket vulnerability, where people using the point of care ultrasound use it beyond their competence. And when that happens, the use of point of care ultrasound ultimately will go down. And the second vulnerability is what they call down market. And down market is when the skills in using the point of care ultrasound in terms of the outcome, the quality of the outcome is less than expected. So in my considered mind, a person doing point of care ultrasound needs to increase they have to start somewhere, but they need to build the skills and efficiency and effectiveness over time. That requires retraining and continuing mentorship and coaching and whatever. Thank you.
Yeah, so I definitely want to piggyback off of that. I think that's the unanswered question in point of care ultrasound, where I find probably the biggest danger in training and train the trainer is understanding when you've reached that certified level, right? I think we all want to be able to know, how do you certify somebody in point of care ultrasound, whether it's OB or general point of care ultrasound? I'll be honest with you, that the answer to that question has not fully been answered across the board. And that's tricky. That makes it a lot harder to understand when can you say, okay, you're good, go out there and scan on your own without somebody looking at your images? Because we all know this, the danger of misinterpretation is a really big problem. And we need to be aware of that. And I think, I'm giving you an answer that's not really a definitive answer. I think I would love to hear a little bit more of that from everybody, because I think a lot of us are struggling with that particular answer. How do you certify somebody, and how do you serially do that throughout the year? When do you check in again to see, a lot of the studies that exist out there talk about doing serial OSCEs, one at the end, which is basically an observed skilled clinical exam, and basically looking at that after somebody's trained, and then again serially after a few months, and then maybe after a year. And then when do you stop? Do you keep going? In fellowship, I was tested at the every 6 month mark for 3 years. Was that enough? As new things come out, how do you continue that continuing medical education? And how do you ensure that people are safely using the technology? Because that is a huge issue. And I fully agree with what Stephen's saying regarding that.
It goes along with what's called the control mastery model of development. I mean, the experts are made, not born. Right? We all learned how to crawl, walk, run, jump. We didn't come out of the womb running. So the ultrasound, the fact that the ultrasound is so safe, this is not X-rays that we're taking pictures and irradiating people. To John's point, if somebody knows how to identify where's the head and where's the placenta, is it close to the internal cervical os? To me, that's a bare minimum start for perhaps saving a mother's life. And if they misdiagnose where the placenta is and they guessed it wrong, without the ultrasound machine, they would never have seen it anyway. It may be asymptomatic until she goes into labor and then she starts bleeding. It's an ongoing study for ultrasound, and as you develop your skill set, then you actually can perhaps then train others. And that's the whole sustainability, scalability that I think is required for these countries. to go in and just hotspot different places, clinics, and get them skilled in ultrasound, doesn't have the scalability of trying to get people, certainly like a radiologist or an OBGYN that's very competent and is a good teacher that could then, we call those the superheroes, and then they teach the heroes, maybe the higher level healthcare providers that do know a little bit more, who the heroes can then teach maybe these skilled birth attendants or the people that actually do go into the rural areas to do some basic screening. So it's a network that really can develop. Are you not going to let them use the ultrasound machine because they don't have a certification, they didn't pass a test, multiple choice test or something? I have a different feeling about that. I think if you want to become a teacher and you want to, teach others, you have to be proven that you know what you're doing, and that's an OSCE, a hands-on assessment by somebody that is an expert. But to get this into saving mothers' lives, right? I mean, 300,000 women a year. That's going back to the plane analogy. That's 10 747s crashing every week. And we're thinking about doing a test for somebody that wants to, that has to certify it. I think,
it's an interesting perspective. Noelle, you sit here, you're ready to say something.
I think I just kind of agree. I think it's what level of test are you doing with the ultrasound, right? If we're talking about dating a pregnancy, locating a placenta, assessing fluid, a heart rate, kind of basic skill set, I think you can get somebody up and trained for those things quite quickly, right? To be competent. Now, not to make complex diagnosis, things like ectopics, I think, are more difficult. You find people that are being trained that then, again, that overconfidence will teach me Dopplers, teach me this next thing. And I think those things really, as Cliff said, like you have your superheroes and you have your heroes. And I think the different kind of depth of training require different kind of levels of certification or observation before you put them out there. But I think that getting people competent in the bare basics, the only way that they're going to stay competent is if they use it, because you can spend 2 weeks with somebody teaching them ultrasound and then they seem great while you're with them. And if you leave them and they don't put their hands on that probe again and they don't scan patients, what you've taught is gone. And so that's what those check-ins are important for. That's why it's so important to have on-ground champions that can continue to work with people to get more comfortable with their skill set so that they reach for the probe every time it's indicated or appropriate, so that becomes their tool of choice rather than this novel technology that they're a little bit scared of or a little bit embarrassed to use because they're not quite comfortable with it. So I really believe in empowering the user and empowering them to use it. I think it is important, though, to caution against overconfidence.
Yeah, I fully agree.
Toward the end of the hour, and I want to be conscious of Guru getting a chance. We have Guru Sundar from Butterfly, who leads our marketing, who is passionate about this topic, to ask some of the questions from our people that are out there before we lose everybody. So Guru, you got some good questions from the audience that you'd like to pose to our esteemed panelists. I think we could keep this group going for a number of hours, but I want to make sure we give our audience a chance to ask questions.
So this came up before, and I'm going to ask, maybe we'll start with Nareen because she was going to speak anyway. Question from Dara, and I wanted to know what value it brings to educate the patient itself to identify symptoms so that they can notify the medical professional sooner. I think this has come up many times, really interesting question. So Nareen, would love your thoughts.
Yeah, so I think this is a phenomenal question that really refocuses us on the big picture, right? So it's not just the buck doesn't end with the device; it actually starts with everything else. And what it is really making sure that the patient has to know when to present. That's always an important part of this. We can't drag people out of their homes; they have to know when is the right time to come. And I think really spreading that awareness of the importance of antenatal care, as well as the importance of recognizing danger signs, is very, very important. And I think I'll piggyback off of that is that awareness should be spread not only to the mothers providers, but to the family members, because we see these big family units, right? In most places outside of the US, we're talking about multiple families in a home. This needs to be a family-oriented approach. I also think that the healthcare workers also need to be aware of that as well. And that's something, you know, most people do know about, but making sure that the messaging is the same. And then a point I just wanted to make is that I do think the physical exam is still important, and I want to kind of convey that.
What's that? Physical exam?
Because, you know, I just want to make that point, is that it has to be, you know, a full approach, that it's not just the device, but we have to be able to recognize what anemia looks like in a patient without a hemoglobin, and what signs we are looking for, and things like that. That doesn't go away as being important. It only becomes a part of the full exam as well. And I think being able to message that is really important. So yeah, I would agree with that comment completely.
All right, Guru, what else?
A follow-up on that, just an answer to that question, Guru. You know, the other thing about the ultrasound in the rural areas is the ripple effect when the patients know about the ultrasound being available nearby, it actually draws patients to that clinic from our experience, and that gives the healthcare provider a chance to educate the patient about other things about health, nutrition, you know, child rearing, etc. So the ultrasound machine actually acts like I talked about yesterday, nectar for a hummingbird. It brings the patients to medical facilities as a secondary effect when it's in rural areas, which we didn't think about at the time. But it's actually very impactful and empowering for the local providers in the rural areas. So educating the patient about the power of ultrasound does enhance or elevate the regional healthcare in general.
All right, Guru, what's next?
There are also studies, Guru, that show that point-of-care ultrasound actually improves patient experience, and I think that's a positive thing. Your question reminds me of the 3 delays: delay in the woman or the family deciding to go for care because of the symptomatology or the signs that they're experiencing, delay in getting to the facility, and of course within the facility, delay in getting the effective treatment. So patient education is paramount. It will increase in a lot of our settings as women get more empowered. Thank you.
Great. It is Mother's Day. We want to empower women, that's for sure.
I'm gonna throw 2 more questions because they've been great, and to everyone that's on the call, we will follow up with answers to everything. For Anisha, who's like extremely data driven, what outcomes or KPIs would providers need to focus on when tracking reduction of morbidity risk for long-term wellness? We'll start with Anisha, and then maybe Bill, I'm sure you have an answer as well.
Yeah, so I mean, from a provider perspective, that would definitely be a great question for Noel or others on the call. I would actually say that while there is data, there's studies, there's guidelines, and I think Noel, you'd agree with this, that this is actually a fairly significant data gap for maternal health as a field. With the exception of cardiovascular health, where there has been a lot more data about the role that, you know, preeclampsia and hypertension in pregnancy and postpartum can play in sort of future cardiovascular health and the risk of preeclampsia and eclampsia in future pregnancies. You know, sort of absent of that, a lot of other kind of long-term implications, data in the postpartum period, you know, considering postpartum yet another phase of the pregnancy, has been really lacking. And so a lot of our efforts and the studies that we fund, we're really nudging a lot of the researchers to include the postpartum phase, even up to a year, gathering additional data to better inform what the needs are and what outcomes look like in that phase. But I'll also defer to Noel or others to add anything to that.
Yeah, I mean, it is so difficult to find actual meaningful, I think, numbers when you're on the ground, even looking in kind of micro locations where we're set. You know, you can kind of grab some maternal mortality statistics, some neonatal mortality statistics, but the morbidities, I think, are the things that you just can't quite get your fingers on. And I think especially in so many of these communities, pregnancy, if we're lucky enough to incentivize them into care, this might be one of the only times they present to a healthcare facility or for care, and get diagnosed with perhaps diabetes or high blood pressure, or some pre-existing disorder that is going to affect the rest of their health and the health and well-being of their family. So I just feel, again, postpartum as the fourth trimester, there's so much data to pick up there and try to reconnect women to come in to follow up their outcomes to really see what is chronic and what is existing outside of pregnancy that these women might still need. But the morbidity data is lacking, I think.
Some of the challenges we had for data, we've tried to collect data, and the providers that we've taught are so busy. You know, they're seeing 50, 75, 100 patients a day, and for them to try to keep statistics to see the effects has been very challenging. We've lowered our expectations about what we can get out of the rural areas and the impact when ultrasound enters a region. What we've tracked is sometimes the number of referrals that have been made to a higher level care based on the ultrasound findings. Trying to track those downstream to see what the outcomes were is difficult, but that is one of our one of the systems we're trying to implement. And even just a number of ultrasound machines in an area. When we went to Nepal, we brought 10 machines over there. This is a few years ago before Butterfly was out. Now they've got 75. We're shipping 40 Butterfly probes to Haiti this week. And that's on top of another 60 that were already in Haiti. And so, just the infiltration of ultrasound into a region is a data point in itself. If those machines are sitting in the closet, our partners would not be investing in these. They would not be using them. So it kind of reinforces the idea that even though we don't have the firm data on the number of lives saved, the ripple effects are somewhat implied by the basic data that we can acquire. But boy, I'd love to collaborate with anybody and everybody to try to figure out, to prove that the worth of it. I know from my partners and from ourselves, we know it works. We know it saves lives. We just don't have the numbers to necessarily prove it right now.
I Googled.
Yeah, thanks, John. One more question. This is for Emilian and anyone else that wants to answer. What strategies have been successful in financing diagnostics such as POCUS?
The way we look at it is how many tests a month a clinic can perform at $15 per test, and what is the price of a device. What we've experienced is that usually at 24 months lease to own model for a device which has a price around the Butterfly IQ. Together with a tablet, together with a stand. So you need to package. It's not just a Butterfly. You need to bring the tablet and the stand and potential printer. So 250 a month times 24 months is something which those clinics could afford if they had enough patients. Now, the biggest challenge that we see is actually the number of patients that that clinic can serve, and the availability of a local sonographer. So what happens usually, if there is no sonographer in the area, women come, the clinic loses the patients, and that they don't get to enough patients to be able to pay the $250 a month, typically. Now, most of those facilities do not have access to any kind of financing. Like they can't get a bank loan, or they can't get any. So you need someone, like in our case, that's what we do. You need someone to be able to offer asset financing to those clinics.
Can I, and this, I ask of the other panelists, is one of the gaps in research is an economic evaluation of point of care ultrasound. I don't know if any of, I personally would love to collaborate in undertaking this research gap in point of care ultrasound.
So it's not really related exactly to POCUS. It's a really interesting topic. I'm a part of the Lancet Commission on Diagnostics. It's happening right now. And we have economists on the team Sue Horton at Waterloo in Ontario, who's looking at the economic model of getting the right diagnosis and how that impacts all the downstream factors. And there's the hard data points of, you know, cost to the system. And then there's the data points you can't evaluate, like, you know, a mom being able to take care of her children over the course of their lives and all sorts of other things and access to society. So it's not necessarily specific to POCUS, but there is an economics evaluation of this commission that's going on currently. It's really interesting question.
Yeah, there's so much here that we could continue to dive into, and I want to be particularly sensitive to my good friend who's now up in the middle of the night, and we keep going. We're going to have him up in the morning to start his day. I want to thank the panelists. This is an incredible topic. We're going to post the answers to these other questions to them that are out there so we can share them on our website. You know, obviously, this is a topic that breeds a lot of passion and opportunity. It's devastating to me that what we've gone through this whole night is we got more questions than we got answers. I think it's very clear, and we got a long way to go. And I think Dr. Kao said it the best. I really wish that we put the emphasis and infusion of capital into solving this problem that we have with COVID. And I don't want to undermine any of the efforts of how bad COVID is, but COVID's going to be here and gone and done. But the maternal fetal mortality is going to continue, and it continues, and it's been continuing. And we've had that pandemic for the last 50, 100 years. And so maybe the words that were echoed here will resonate more, and then together we can work collectively. And one of the chances we didn't get a chance to talk to is how do we get everybody here to collaborate? But we'll bring you all back and do another one of these because there's enough rich material here to keep going. But we want to stop here. Thank all of you again. We appreciate it. And Chris, if you can put up that slide, I think the one thing I want to leave everybody with in our audience is the opportunity to reach out to us at Butterfly if you want to connect with these people. Get involved, be part of the difference. These great people that are here on this webinar are people that have left the comforts of their own practices to make a difference. And I think that we'd love to see more people can do this because it's not just technology, it's not just education, it's people, and it's people making a difference. So I want to thank all of you guys on the panel again, and ladies, happy Mother's Day to the mothers out there and to the mothers on the panel. And we look forward to seeing you again on the next Butterfly webinar.
Okay.
Great.
Bye-bye, everyone.
Bye.
Thank you.
Everybody have a great night.
Thank you.
Thanks. Bye-bye.